Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Education and Partnerships at SICA, where we partner with healthcare professionals and clinicians to offer body composition solutions. I'm so excited to be joined today by Dr. Jeremy McConnell, who is a sleep medicine and an obesity medicine specialist. Who also struggles with both sleep apnea or did struggle with sleep apnea and obesity. And so today we're going to pivot a little bit and talk about his story and really get into sort of the crossover of clinician and patient and what that really means to understand both. So thank you so much for joining me.
Thank you very much for having me.
So I know you and I know each other from, all the various meetings, and I think, really excited to have you talk with us more about the connection with sleep and obesity over the upcoming months. But today, when we started talking, I really was so impressed by your story as it relates to, being a patient, or someone who's struggling with the disease that you treat, but also your experience with body composition and how you've been able to change yours. And so I thought it would be kind of fun to go the route of, we know you're the professional in this area, but let's hear a little bit more about you as the patient or the person, kind of that human side.
Yeah. Thank you. And I think it's, stories for what it's worth. I think we live by stories. We share stories and tell our personal experiences, and we have a lot to learn from one another. And I just hope that maybe my story influences others to maybe tackle some of the challenges a little bit easier. So, yeah, I grew up in, very close-knit family, mom and dad, and I had two brothers. I refer to us as Irish triplets. My older brother was about just a little bit more than a year older than I, and my younger brother was a year younger. And so with the three of us together, if you can imagine, so in families like that, you go everywhere together. You do everything the same, and
Dress
for
the same.
you dress the same, right? You get the blue shirt, you get the yellow, you get the green, and and so we were just always together. But what was really interesting about my experience was at a very young age, I developed obesity. As far as I can recall, I was probably about 4 years old. And so it was just different. I grew faster than my siblings. I was larger. By the time I was probably 7 years of age, was the first time I recall addressing my weight. And essentially, my parents addressed it for me in a sense. And so it was interesting as a young child to grow up that way. And so going to the University Medical Center, now you have to remember, this is around 1980. Okay. So
Yep.
our advances today, we didn't have those things then. Went to see it was probably a pediatric endocrinologist, and they did some lab work and they did some testing and they didn't find anything wrong per se, but it was just noteworthy that I was growing and fast. And, by the time I was 7, I was taller than my mother,
Wow.
a full grown adult woman. And I remember growing up that way, and I would always stick out as the kid, on the school bus or on the playground or what have you, and always being teased about it, always being picked on and bullied by the older kids and other kids. And so it was difficult to grow up with that experience. And what was always a little bit strange about it, I wasn't self-conscious about it at the time because, at that age, you don't internalize that yet. Right. I think that came a little bit later, but it was certainly a factor. I didn't really understand, of course, that was just me. Why did my brothers not have that issue? And so it was kind of a challenge to experience that growing up. I think it really began to affect me more from a psychological perspective by the time I was about 8 years old or so. There was an awareness that this was my situation, and that was distinct from the other children. And so I think we've gotten better as a society on how we address differences in children. But in those days, things weren't exactly, shall we say, warm and fuzzy.
No.
People were a little more blunt. They were a little bit more and less accommodating when it would come to things like gym class and, school events and so on. And because of my weight, and I was prohibited from playing sports with other kids my age.
Really?
Yes. So of course I wanted to play football desperately. That was my game. And I couldn't because the Pop Warner leagues at that day and age had weight limits. I suppose they still do now, but I was exceeding that. And so I couldn't participate in social functions and in school functions, sports activities with other children and my mates, So that was kind of difficult growing up in that scenario.
That's wild. I'm not from an athletic family at all, but I would imagine, just the advice too at the time, around, okay, hey, you're heavier, but let's restrict you from the athletic
I know, right?
portion of the equation. I mean, that's wild.
Yeah, and so it was challenging. I remember going to my first Weight Watchers meeting at 8 years old, and it was extremely awkward. It's in the church basement meeting room kind of thing. There's 15 to 20, middle-aged women there and me. And it was, you know, I know my mom was doing that to help me to engage and to learn about healthy eating habits and so on. And I think that's really where my foundation began at understanding eating in a healthier way for what it was at the time. Okay. For
Mhm.
what it was at the time. And
Doing
so,
the best with the tools we had at the time. That's a
exactly.
Brene Brown thing I always have to remember to say.
That's right. And, and you build on those experiences, right?
Yeah.
And so it was an interesting time frame for me because of course that didn't feel very good to be in that environment. Always a little bit awkward. Um, one quick story about that I can recall was there was we would always go out to lunch afterwards. So it was like we went to the meeting, right? And so there was this like educational component about health and well-being and so on. And then of course we go to lunch after, right? But it was kind of like that reward for having done that sort of thing. Bit
Mm,
odd. But it wasn't until I think I was about 12 years old that I experienced a bias from a healthcare provider. Okay, shame actually.
mm,
So it was a really interesting experience, and I know the audience will probably appreciate this, but I had a slipped capital femoral epiphysis, which is an orthopedic condition, which is more common in pubescent boys with obesity, and it's always on all the board exams. So the family medicine board exams, I'm sure it's on the pediatrics board exams, and so I always got that question right. So there I was, right? So I had this pain in my hip, and my family physician knew what it was and sent me immediately to the orthopedic surgeon. He came in, kind of said, "Okay, this is what's going on." Put up the X-rays, said yada yada yada. Said essentially we have to have surgery. And I was 12 years old. Okay, tell a 12-year-old they're going to have surgery. That was
yeah.
certainly intimidating. It was scary. And he just turned to me and he just said, "You wouldn't have this problem if you weren't so fat."
Oh,
And yeah, 39 years later, I remember it. I remember where
exactly.
it happened. I remember how it happened. I remember verbatim the conversation.
Oh.
And that was not, yeah, that was didn't it kind of hit me in a way. So later, as I progressed in my work clinically, a couple things I learned from that experience was your words matter.
Mm.
The things you say to people, how you say it, make a huge difference in your approach, and probably also in your interpersonal dynamic with them as to how effective you can be from that therapeutic interaction.
And the
So
trust. I mean, you have to then
trust,
go undergo surgery with this guy.
yeah. Now everything turned out okay from that, but the sequela of that and how that episode has subsequently influenced my career and how I talk to patients. You know, we teach in obesity medicine. We teach to ask permission to talk about weight, and that resonates with me tremendously. And sometimes it's awkward to ask, "Hey, is it okay if we talk about your weight?" It's a weird question to ask, but I think it's an entry point. We have this duty, I think, in healthcare where people give us permission to speak into their lives in ways that they don't permit anyone else, right? And
Mm.
so we get a glimpse into their internal, who they are as a person. And I think there's a trust there that if we abuse that, it can be pretty harmful. So we have to keep that in mind. And I think we can use that for the positive in terms of, say, motivational interviewing to get them to kind of come along with you in that journey. But that episode really, really stuck with me quite significantly, formatively in my clinical training. It wasn't long after that I decided I wanted to be a doctor. So
Really?
yeah, I was probably 14. So these different experiences build on each other. But it wasn't until I think I was maybe a sophomore in high school that I had my first episode, I would say, of success with weight loss.
Mm.
It was an interesting time. I had a wonderful, he's actually a legendary high school sports coach, Hall of Fame and everything. And he said to me one day, he said, you're the best offensive lineman on our football team. He said, but I'm not going to start you until you can keep up with the team. because of my size at that time, I was probably 265 pounds. I didn't have the endurance to stay with the
Mm.
team drills. And so I think he approached it the right way. So for anybody who has influence with teens and adolescents, obviously our approach, and we're talking about that a little bit here in communication, but he said it respectfully. He said it with love, right? It wasn't, a harsh statement. It was, hey, I think you've got an incredible talent here, but I want to encourage you to really hone in on that. And so that's what I did. And so I began studying nutrition, studying macros, studying these things, and putting that together, and exercise and intentional, activities to do that. And over the course of several months, I think I lost about 60 pounds or so. And that was a real difference maker for me from an athletic perspective, because now I could perform at that level, more fully with. And so that was the reason why I bring that up is I think I use the example of the orthopedic surgeon perhaps as the negative, but there are people in our lives who can be influencers for the positive. And so, obviously finding them and doing that is key in
Well,
our
and I
case.
think the other piece of that a little bit is the blame on, like,
Oh,
the whole you're a bad person shame versus, like, you're a person who has this attribute, right? And like
yeah.
focusing on fitness and saying, you're a good person, you're a good athlete, but fitness is something you can improve at any size, and not having it be about your size. That's what that feels different to me.
Yeah, I think you're right. I think you're right. And I think that my experience at that age, I was about 15, I think, 15, 16, somewhere in there. But my experience at that level, um, because I think that I had an internalized shame about my weight for years prior to that. And that was the first instance that I had had some degree of success, as I said earlier. But what that did for me was made me think what was possible,
Mhm.
right? So my personal experience in weight loss helped me to realize as I went forward in my career, even though I continued to struggle with it, that this is something I can achieve, right? It was empowering. It gave me the experience of knowing that I could do something about it. I think a lot of our patients miss that or don't have that either they lack the drive and internal drive, or if they're anything like me, they had some of that negative self-talk that would say, why bother, right? Why bother? This is going to be
Yeah.
hard, and it's going to be another diet, and you're going to go forward on this, and you're going to fail again. And I've experienced all of that. So it's an interesting experience, I suppose. And I think it's an important one when relating to our patients.
Well, and that negative self-talk being also met by the external confirmation that, yes, you're right, you are bad, you are shamed, you
Mhm.
are, this is something that you did brought upon yourself. I mean, hearing that message when you're so young and at a formative age is really hard to come back from.
Yeah, I think so. And for the years subsequent to that, I had some ups and downs, weight gain, weight loss, and in the cycles of weight loss and weight regain, what I had come to determine, I guess, internally was almost a sense of hopelessness.
Mm.
That no matter what I try to do, this is going to be, you're not. It's futile. You're not going to have success at this. And that changed. So just to give you a clue as to what that looked like. Now, at this point in time, I'm talking pre-med, med school,
Okay.
residency, and even into my early career as a family physician, and also pursuing obesity from a career perspective. Um, it wasn't until around 2011 that the pathophysiology of obesity began to be talked about more, right? So the experience of weight loss, and then the metabolic adaptations that patients experience, and then weight regain, and so on and so forth, became really published and talked about. And it was like light bulbs went on. I'm like, oh my gosh, that's me, right? This is what happened to me. This is the cycle of what happened. And it wasn't until about that time that I stopped blaming myself.
Hmm.
Okay. Because I didn't understand it from a scientific perspective.
Right. The biology explanation clicked.
Yes. Now that's what worked for me, right? So I don't know that that's the case for everyone. But once I realized that my lived experience was consistent with what these, papers and authors and experts in physiology were talking about, I was like, oh my gosh, this is what I'm experiencing. Um, And it just, because for years prior, I would look at it as, you've been able to handle hard things. I mean, you're a physician, for crying out loud, going through all that, going through residency. Why can't you control your weight? I mean, if it really is calories in and calories out, just simply follow the plan, right? Well, as we know, there's a lot more to it than that, right?
It's even more, I think it's even more difficult when you know it and it's like the divide between the how complex it is even bigger. If you don't know all that and you're just sort of struggling, that's one thing. But when you know it and then you're still struggling, I think
Yeah.
it compounds how you take it a little
Yeah.
bit.
And I think one of the things that I learned in the past couple of years, I really spent a lot of time talking to my patients who were having different degrees of success and asking them, what do you think are the most influential aspects of your weight loss journey, but specifically working with me in that journey? And I was always a bit reticent to share my personal story. And the reason why I was because I didn't want my patients to think that they had to do what I did. Right. And just because a particular style of eating and exercise regimen, what have you, was what I did, does not mean, of course, that it's right for everybody else. And so I kind of was very sensitive to that. But then when I found out that sharing my story with them and my successes and failures, I think in some ways gave them a connection to me in a way that further permitted me to speak into their lives as to
Mm.
where I saw they needed. And then applying that knowledge and experience from an evidence-based perspective and helping them to craft a plan to work through that was really key. And so I started doing that. I started being more open about it. I started being, because people would look at me, and this is always fun. So, let's say at 275 pounds, they would look at me and say, "Oh, why should I listen to you about weight management?" Right?
Yeah.
And I would have this in my mind too. I would go and give a talk at an obesity conference or at maybe a sponsored meeting or something. And I'm like, these people are going to think I'm an idiot. These people are going to look at me and go, why should I listen to him? He clearly doesn't know how to manage obesity.
It's such a narrow range what you can be to be sort of trusted and understood, right?
Yeah. And so then I lose weight, right? After, and we'll get into that in a second. And then people look at me like, well, how can you possibly understand what it feels
Yeah.
like?
Yeah.
And I would see the opposite reaction. And so it's always one of those things where managing patients' expectations in their own eyes and the bias and the internalized bias that they have, even against themselves, they extend that to others. And so,
That
so
opens the door, though, that no matter how you frame it in that type of a way, it does open the door to say, "Oh, yes, I would have thought that." Or, if you're bringing it up first, I think that really helps. It does help make that conversation a little bit, more human and more understandable and
relatable. Yeah.
relatable. Yeah.
So now when I give a talk on obesity, one of the things I like to do is to open it up and say, I have obesity. I've had it for 47 years. And it's something that I really deal with. And not that the story's about me, right? It's not about me, but we want to share. I think sharing those experiences helps people to relate to it in a manner because they look at you and say, well, what do you mean? So when I'm speaking specifically to colleagues in healthcare, I use the analogy that, you don't have to be old to be a good geriatrician.
It's a good one.
And you certainly don't have to be a child to be a good pediatrician. So we have these biases, right? And so you would look at maybe a cardiologist, and if a cardiologist has coronary artery disease, that makes him a bad cardiologist. It's like, that's ridiculous. So it's part of being alive. It's part of the human
Right.
condition. We're all going to have some health ailments, right?
Or the addiction field, where a lot of, I mean, that helps usually, give that, background to say, okay, you understand this.
Sure.
Weight just has this special complicated place where it's like you can't be too much on either side for people to really understand it.
So what I try to do with patients is I teach them about metabolic adaptation. I teach them about the physiology. I teach them about, the fact that this is a chronic problem. This is a chronic condition, and we want to make incremental improvements. And it's going to take time, and you have to look at this longitudinally. And and as I tell them a little bit about what I've gone through to achieve where I am now, they kind of look at me like, oh boy, I have this problem and I've got this resistance against weight loss. So speaking about body composition and the role of that and all the different tools that are available to us today on how we can make the journey, I think, better for the patient are really relevant. And so, for me, I had reached 330 pounds at my heaviest, 5'8". I think my driver's license says 5'9", but really 5'8" because my Sika scale tells me how tall I am. Can't hide it there. Um, but the uh, but I had done some ups and downs, and I started my first use of an anti-obesity medication, I want to say in about 2011, give or take. And so through that time, I had lost weight, regain, weight loss, weight regain, and so on. But when I was 44, I was about 275 pounds. That's when I developed sleep apnea.
Mm.
So as a good sleep doctor, test myself, right? So there it was. And so I struggled with tolerating CPAP. It
Mm.
was like a lot of our patients. It took me months and months to really acclimate, and I had every resource available to me. And I think it was at that point in time where I realized, I hadn't yet had any of the metabolic consequences of my weight, but I in a sense, knew what was coming. And so it was at that point, after having been on an AOM for, I don't know, 5, 6 years, and using whatever the latest and greatest was, whatever I had access to, where I really realized that it was time for me to have weight loss surgery. That's where I was. And so, it's a weird feeling to decide to have weight loss surgery. I mean, a lot of our patients, they go through this, and probably clinically, we look at it as, well, yeah, you have surgery. And it's just like, matter of fact, clinical kind of context. But the internalized shame that many people with obesity feel, including myself, was like, oh my gosh, is this what it's come to? Is
Yeah.
this what it's come to? I remember sitting in pre-op on the day that I had sleeve, that I was literally asking myself, here you are. Now, I had mixed emotions about it because I knew what the outcome, the positive side, was going to be. But the negative self-talk of, wow, you've let this go.
Yeah, the narrative I think around surgery for so long, I was just talking about this earlier today, was just this is the last ditch effort. You had to
Mhm.
be at such a severe level, even all of these horrible TV shows that they have that frame the patient at this end of the line when now, 15 years later, I feel like we're finally at that place of earlier intervention, might have better or does have better outcomes. That narrative has changed since I've been in the bariatric space since 2007. And
Mm.
that's what it was. We were asking patients, have you done everything that you could possibly do to get to this point? And now, the surgeons would talk about it like, this is your one chance, like, don't screw it up. And now it's a completely different conversation and
Yeah.
much more empathetic and patient centered. And it's a journey, it's a lifelong, it's a progression
With
from
recognition of the
medication and surgery.
pathophysiology behind it, right? So it's,
Yeah,
I always like to say, attack the problem, not the person. And I'm gonna when I have a new patient and we talk about their treatment choices, I'm like, let's run, let's go, let's link arms, let's throw down, let's go, let's do what we can do, meeting them where they're at, right? Because they're not always ready for all of these different things that we throw at them. It's a gradual progression of acceptance of these things, but all the while always attack the problem, not the person.
I love
And
that.
and so I think that's just resonated with a lot of our patients, that some interventions work better for others, right? For some rather than others. And just that's the way it is in anything in healthcare and in any of our treatment modalities. But bringing it all to bear, right? Bringing it all to bear, using things that have evidence. This is one of the things that really bugs me about our current state of affairs in obesity medicine is, there are things that are out there that are popularized that don't have very good scientific merit. And I think one of the most important things we can do as credible clinicians is to call those things out and stay away from them as much as possible, because your patients are going to take I joke about this when I say, like, hey, if I told you that if you jabbed this pen in your eye, it would make you lose weight, there's going to be a certain percentage of people who will do it, right?
Isn't that wild?
It is, but we have the potential for great harm as well as we have the potential for benefit. And if we place our trust, our money, or our emotion into the perspective of a potential therapy, that lacks merit, it's highly unethical. And so I think we damage people
Mm.
when we promote things that don't have good merit. So
And
anyway,
you cause them not to come back. I mean, you don't know that that could be the last straw for not coming back for future healthcare, you know?
you're so right. And we know about the discrepancies in healthcare screening and so on and so forth and routine general care that people with obesity do not engage in to the same extent as others. And so it's a real concern. It's a real
Yeah.
concern. It's a power, but it can be abused. And we have to be careful about that.
So surgery for you was 2011,
No, 2018.
18. Okay. All
Yeah,
right. I'm
that's okay.
trying to
That's the
keep
time.
up on the timeline. Okay.
It's been 7 years, just past 7 years. Yeah. And so back then, if you recall, the application of anti-obesity medications in patients who've had bariatric surgery was still considered kind of fringy.
Mm-hmm.
It was out there a bit. There were limited studies published,
Very limited.
limited experiences. Nowadays, it's actually much more accepted. But but this was an interesting thing for me because I knew the effect, the metabolic effect of having sleeve, the impact that it would have on hormones like GLP-1, and I knew that the time frame of benefit was going to be somewhat finite. And because of my weight loss and weight regain cycles that I'd had in the past, I was kind of projecting that I wasn't going to lose as well because of
Mm.
that recurrent weight loss and weight regain. So I think it was about 7 or 8 months after surgery, and I had probably lost, I want to say 20% of my body weight at that point.
Okay.
Not bad, not bad. Where I started to get recurrence of the want and desire to eat and the poor satiety that was my fundamental problem going back, at the basis. So
Right.
it was at that time that I started back on. At the time, it was Saxenda. That's what we had available. So I started back on Saxenda, which helped me just to kind of accelerate my loss a little bit more for a period of time. In which case, after a few months, I began to plateau out again. And that was when Ozempic came on the market.
Mm-hmm.
So our friends at Novo Nordisk, I was able to access that. And with that, it helped me to continue to lose weight down to about 170 pounds. So it was about 100 pounds weight loss at that
Okay.
point. So all the while, I had my Sika scale, of course. And so I was measuring my body composition as I was doing that. Um,
Oh, we
I
need to pull your history. We should
I
do
know,
that.
right? So I continued to lose. So, it's funny, mindset, right? Where your mind is and where your mind's eye is about your body and what you think about your body and your goals accordingly. For me, it became kind of a challenge as to where I could take this. And as I was approaching 50, I started thinking, you know, um, let's dare to try. Let's see what happens as I move forward in this journey. So I was, I'd reached down to a lower weight than I probably should have been, probably in the 140, 150 range. My BMI at the time was about 21. So on a
Okay.
BMI perspective, not necessarily, but visually, I had probably lost too much. And I hopped on my Sika scale. I had not done so in a little while. And I was surprised to find that my skeletal muscle mass was kind of at the low end
Mm.
of my age match norms. And I didn't like that very much. And
This is that inner athlete competitor.
exactly. There was another component to it too that I didn't share with you yet, I think. So we also measure resting energy expenditure by indirect calorimetry in our practice. And I first started measuring that in 2004. And my resting energy expenditure was always 20 to 25% below my predicted.
Okay.
So I was I would say conservative with my calories. My body was very conservative. And so I saw that because I repeated my resting energy expenditure at that time when I was at that weight. And it was like 1,200 calories a day. It was quite low. And I was like, all right, this is going to be a challenge because if I don't add muscle mass, if I don't do something proactively to protect what I have, but also add into it, I'm going to be in trouble if I don't have access to my AOMs. And what happens, because at that point now I was on Zepbound. And so I was like, that's what I had to do to maintain. So that was when I said, this has to change. This has to change. So I began this process. Again, I dared myself to try and just simple, weight training 3 days a week. I still had all that knowledge back in my days from playing football and stuff. And so went and did that and started doing some actual cardio exercise as well. And then within a relatively short period of time, I couldn't believe how my body responded. because within about 6 to 8 months of increasing my protein intake, so I kept my calories neutral, probably 14, 1,500 calories a day. And I intentionally increased the proportion of my calories from protein. And
Okay.
I was really targeting to get somewhere in the range of 140 grams of protein a day. And so I started doing that. And then I started weight training. And that increased to 6 days a week with 1 day off and walking about 20 miles a week. My feet can't take running anymore. And kind of progressing with that, my weight increased to about 175, but my body fat percentage stayed around 12%, 11, 12.
That's such a thing that normally might freak you out, but you had all this data to be
That's right. And that was
playing with.
that was so important, and I'm glad you mentioned that because in my mind, I'm going, "Okay, I know this is healthy weight gain. I can feel that it is." And of course, I did increase some fat mass. I'm not going to increase strictly lean mass. You can't do that really. So maybe in under extraordinarily controlled circumstances, one can do that. But for me, it was I expected to gain some fat mass too. And so that was a real challenging experience to go from say 145 to 175, but adding roughly 25 pounds of lean mass.
Wow.
And so, yeah, I was a little bit of a data junkie, kind of like monitoring
I
that
can picture it. I can see your spreadsheet right now.
spreadsheet and, and looking at those changes and saying, okay, if I gained, let's say this month, if I gained 4 pounds, what was that, right? What was the composition? And I think that for me, I think it really showed me, again, what was possible. And then I started, at the age of 50, being able to do things physically I could never do before, even when I was younger and stronger.
Wow.
I could do. And so I'm thinking, this is kind of fun. Um, so for me, it was kind of a dare to try, see what see what can come of it, and where am I going to go with it now? But I still monitor my body composition at least once a month. And some people might think that's obsessive, but I don't weigh myself but more than once a week typically now. And I just try to keep my macros on point, and I'm not obsessing and tracking every morsel. But if I feel like I'm off track, I do, and I'll go back to it, and I'll start tracking again, reset my compass a little bit, and then
Mhm.
use that accordingly. And I stay on the medication. So I stay on Zepbound because I found that when I would start to reduce the dose and try to taper that off, my want and desire would come back. My appetite would come back. And that's a really slippery slope for me that I have to be very careful about. So
One of the things I'm loving about what you're saying too is just looking at several different, components, not just weight, not just body composition, how you're feeling and the way you're sort of talking about it clinically, of course, but sort of the want and desire piece. I mean, I know people who are staying on medication without change in their body composition or weight for that primarily because it works so well at a component of the equation that's so intrusive to some, you
yeah,
know?
I like to say that for me, I think I don't, you can't measure this really, but I think I have a signaling problem in my anorexigenic pathway. And so I think that the satiety signaling is probably not heard by my brain. And so when I was younger, of course, and now I could, but although I've had sleeve, that would be restrictive, but I could essentially continue to eat until the point where I was uncomfortable.
Hmm.
Like the stop signal just wasn't there. And then I joke about it when I'm giving talks and such. There are certain foods I cannot have in my proximity. And if they're there, like Tostitos with a hint of lime, one of my favorites. So chips and salsa. So if I have those in my environment, it's like I almost know that it's there. And I'm exaggerating when I say this, but it's sort of like if it's there and I see it, I will want to eat it. So what the medication enables me to do is it's a behavioral tool for me. It really, people talk about food noise and that kind of thing. It really kind of attenuates that, and it slows me down so I can make the next right choice. Am I perfect? No. And am I going to eat things that are, food is meant to be enjoyed. There's a certain component, it's a hedonism to it that we all enjoy. The rule of thumb that I try to follow is not to waste my indiscretions on junk
Yes.
stuff. If you're going to get it, get the good stuff, right?
Yeah.
Um,
But
and
it's
just
that balance of enjoyment, satisfaction, there's so many different components of it. I think one of the things I'm also, really loving about your story is just the complexity and the nuance. But
mm,
now looking back, you're able to to comment on it and to see it from that bigger picture. But when you're in it, that's hard to do. And,
Yeah,
being able to balance all of that, it it requires a lot of work. And it sounds like you've really worked at it, and you have a healthy understanding that you'll always have to maybe pay a little more attention to that
mm,
component, because it has been a struggle and it's not something that goes away just because your weight reduced, you
that's
know?
right. And so I think you bring up some really good points that I just kind of recalled. In my decision making to have weight loss surgery, I was already putting in the work, right? So a lot of people think you just get cut and that's that. And then, you just say, oh, no, it's work. It's work, right? You have to transform, especially early on. You really have to look entirely at your entire lifestyle and ask yourself, how am I going to manage my day accordingly? Because of the what happens with surgery, it's thrust upon you. That's what happens. Um, so for me, my view was I was already following a reduced calorie diet. I was already using the state of the art medication at the time, and I wasn't seeing the results. And so I knew I had to go from here to here to achieve the health goals that I wanted to achieve for myself. And I knew I wasn't going to get there on the regimen that I was on, that I would have to intensify my regimen in such a way to achieve that outcome.
That might not be sustainable.
It might not be sustainable. But if I'm putting the work in anyway, I surely would like to get the outcome.
Yeah.
And so I think for a lot of our patients, there's this, and I experienced this sort of sense of futility, right? I'm doing all of these things, and I would like to see the fruit of my labor. And so for me, that's just where I was. And that was like the tipping point. I mentioned also earlier the risk of comorbidities that weighed on me at that point in a manner that it didn't before. I feel like I got away with it for 25 years, right? Or longer, where things didn't quite catch up with me.
Right? Maybe because your
Yeah.
age, or yeah.
Yeah, good genes. I don't know. I mean, I have obesity in my family too, but it doesn't necessarily come with a lot of the comorbidities. There's quite a bit of diversity about that in a population. But that was a turning point for me when I realized, okay, it's time. The other piece was, and this is a longitudinal understanding that took time to build, but it was the understanding that I remember sitting one day and just going, this is obesity is not something that's really going to leave me. This is something that's going to be a part of where I am. I have no evidence to suggest that I'll ever be cured of this condition. And so I had to come to terms with the fact that those are the cards that I've been dealt, and that's what I'm going to have to address. And it's right or wrong, good or bad. You know,
Yeah.
I don't want to deal with it. I don't want to have to deal with it. And so I
But that's
talk.
a mindset. That's a big mindset shift.
It
That's
really was.
important.
And I talk with patients about this. I'm like, I know you don't want to be here talking to me today about this problem. Okay. I know you'd rather not, wouldn't we all? But the fact of the matter is that I had to acknowledge that its chronicity, the life lived, the years of this were not going to go away per se. I was going to have to take the actions that were going to be necessary and choose to, albeit imperfect. That's the way it's. So I'm so grateful for our innovative scientific community who's coming up with better and better solutions because, you know, maybe 20 years from now, I'm going to need
I
something.
need it down the line.
I don't know yet. We'll see. But it's been an incredible journey. And, you know, it's the colleagues, the people, the support, the field. It really is a unique sector in healthcare and sector in medicine for the people who, our colleagues, that we meet with and get to share these stories with. It's just so much fun, and just to kind of hear where people are making substantial health improvements. So much of
Mhm.
our healthcare system is focused on fixing an acute problem, right? I call it plugging holes in the dike. You're trying to fix things. Obesity medicine gives a perspective that I think is very different, and where we can really work with people on health promotion
Mhm.
instead of just simply damage control. Um, yes, there is damage control, but it's not just damage control. There's health improvement that goes with it.
Yeah, it's funny. I think something you said a little bit ago really resonated with me as a dietitian, because, in this era, people are always asking, well, what do you think about these
Yes.
medications? And it's back to how I felt, in the early thousands of, well, what do you think about surgery? And it was kind of this, is it like the Easter bunny, right? Do you believe in it or not? And I'm like, well, like the evidence is there. It's not a question anymore, right? But as a dietitian, I think many of us went into this field to sort of help people with their food and eating and all of that. And there was always this view of like, well, we're going to learn what the best way to do it is and then tell people and they're going to follow it. I don't know. Maybe that was me. I thought that was how it was going to go.
We all think so.
Doesn't, right?
Yeah.
No, I had to get a PhD to figure that part out. That was a wild one, right? But we think that we can just sort of help people by giving them the information. But what I think is so cool now that we're seeing so many more people have medication as part of their story is that the biology part gets taken care of. So patients that are coming to you are like you who they doing the things or they know the things or they've had long history of doing these different diet, exercise, behavioral components. But now that you're sort of taking the food noise, the biology, whatever it is down, like they can do those things and your job becomes actually easier to help
Absolutely.
people do the things they've always wanted to do. And that's what I like. That shift is such an interesting part. I felt that way with surgery, but surgery, tackled, 200,000 or so folks in the country. Now we have so many more people seeing like, oh yeah, I've been eating this way all the time, but it was futile. And I've been trying to do this. And then I gave up because it just sucks to kind of pursue a goal that you're never meeting or the goalpost keeps moving. And so now I think it's
Right.
a really exciting time for all of us in this space to sort of help people and they're seeing results, which motivates them to keep up with it. So it's actually like the opposite of a downward spiral. And that's another place where, there is a lot of joy in helping people in that way. And for me, adding in the body composition piece is even more exciting. When people say, I'm okay with gaining 30 pounds because I care that much about being a healthier old person and being able to do all those things that you say functionally, that's even more exciting. I
It
love
really is. It really is. I think touching on the so I don't remember when it was. I purchased my first body composition BIA device in 2004. So I've been using it for a long time and looking at the different information that's gleaned and how we use that, not only to assess people in their progress, but also to reinforce their positive decisions, right? So we're seeing cases now, and as you know, this happens. It happens in the bariatric surgery world as well, where someone might go, let's say, from a BMI of 40 down to a 22. Okay, I mean that's a stark change. It's a huge change, and so then you have their other healthcare colleagues in the community who, and the patient will come in for their follow-up and say, "Oh, I saw my primary the other day, and they said, oh, I can't lose any more weight. I need to stop this medicine," and so on and so forth. And I'm going, let's measure you. Let's see where you are. We've been measuring you all along. So we've been tracking your progress. Let's give some credence to the concern. Okay. But with these newer medications, we're seeing magnitude of weight loss that is so significant that now people are going, whoa, you've gone too far on the other side of the pendulum has swung too far to the other direction. So I use that information, my body composition information under those circumstances to validate that the patient is doing well. And then we'll take a look at their protein stores. We'll look at things like their albumin and pre-albumin and show them they are adequately nourished. And we're tracking their nutrition. We're looking at their data in a manner to say it is okay to be a BMI of 22. Just because it's not the norm today does not mean that that's not okay, right? So that's one element of how we use the body composition to monitor that progress. Obviously, we're looking for people who are losing a disproportionate lean mass loss so that we can underscore and emphasize the nutritional changes and behavioral changes and physical activity changes that we need to incorporate for their success. That's probably the main way in which it's used. I think the new application with Sika, it's been up for at least a year, but where patients can track and see their data longitudinally and kind of know their numbers. I think that helps patient engagement in our practice. And I can't imagine practicing obesity medicine without knowing that information. I think it adds a certain level of scientific veracity to what we do on a day-to-day basis that reinforces how our patients engage with us and know that they're on the right track. Do you know how many 70-year-old women I've been able to convince to do resistance training? Do you
That's
know? I mean,
awesome.
like, yeah. I mean, you don't look at your average 70-year-old woman as someone who's going to go to the gym and do resistance training, but they sure as heck should, right? And we know that.
Yeah.
But sometimes it takes a number on a piece of paper or digitally or what have you to see that and go, yeah, you're right. I need to start doing that, even
Yeah.
though it may seem unusual or contrary to what they expected as far as an intervention. And it's fun. It's fun. I love
Yeah.
seeing women come in and they're like, "Look, doc, I got muscles." You know?
I love that. It's also, just one of those. I've had people say, "Well, how am I going to change my practice with it?" I tell everybody to do this, and of course, I get to say, "Well, all or nothing blanket advice. How's that working for you?" It's
Yeah,
not right,
I
but
think
you've
for
got to see your own numbers. You've got to
right?
see where you rank up and how you've changed, and that's just how we are. We're visual data hungry people.
Yeah. And I always, I'm in the mindset of, okay, let's touch as many people as we can, and we can give general recommendations and blanket recommendations, and that might work well for a certain percentage of people, but experience tells me that it really doesn't. The notion of what we do for people does have to be personalized. I mean, I like to say it this way, you can have a template to work from, but you have to be able to customize the concern for the individual, right? And that's a great point, and that's one way in which measuring body composition reinforces those principles for each individual patient. Yeah. And sometimes they don't like the numbers that they see.
Right.
But
Well,
but a negative
it's
response
that
can be
dose of reality like you showed. I mean, I really resonate with what you said earlier about I don't want to have to do this, or people say like I'm not really a pill person, I'm not really a medicine, shot person. I don't know about surgery. Like,
yeah.
yes, nobody wants those things as first line treatment if there is another way that's sustainable. And so that's
Yeah.
where you
It's why I like our
go to
friend
school
Angela.
for all those years to figure that part out.
Yeah, Angela and our mutual friend Angela Fitch, she talks about that. She's like, maybe you don't want surgery, but maybe you need surgery. Maybe that is the right thing for you in the
Yeah.
context of one's personal need, right? Or whether it's Zepbound or some other medication, right? Or Wegovy, whomever. But saying that I don't want to be on a medication, but this is what it's going to take to get you from here to here.
Right.
And that's kind of where we are. All I can say, as I said before, I'm thankful that we have more interventions, both in pipeline. Oh my goodness, it's an exciting time. I think to quote another one of our dear friends, Harold Bays, he always says, "Buckle up. What is coming is greater than what we've had," and it's a really thrilling time today to explore where these different pieces intersect. I mean, we've got our first FDA approved drug to treat sleep apnea. How cool is that?
That's
So,
crazy.
and I know it's not going to be the only one. There'll be others. And so what we're doing for our patients today was, I don't want to say was unthinkable 5 years ago, because those of us in the know knew this was coming. But I think for the majority of people, it was unthinkable 5 years ago,
Mm.
that we can do these things.
And for a group who has been marginalized and hopeless, as you said earlier, if you were in that realm between need to lose a little bit of weight and could do that with lifestyle or had access to surgery, for everybody else in between, it was quite hopeless for a very long time. And so I think on that note, there's hope. It's really exciting. And I think, there's more and more people wanting to get into this space as
Mhm.
clinicians and get specialized in this. And hopefully they can take, stories like yours and be able to practice with a little bit more humility and compassion and empathy and be more effective. And I think it's a hopeful time.
Yeah, I think I would say to my colleagues who are interested in this, as I do, talk to people about this all the time. There used to be a phase. So when I certified with the American Board of Obesity Medicine, it was 2012. I think it was the first year. Most of us had been doing obesity medicine, and then we took the exam to get the credential. Okay. And what the ABOM did is it set a standard for certain knowledge that we should have, right? That was one of the key aims of the organization. Today, it's a little bit different. Most of the clinicians who are sitting for the ABOM exam are like waiting to pass the exam before they jump in and treat obesity.
Mm,
There
you're
are
right.
way more people with obesity than all of the ABOM certified physicians can possibly treat together we need everybody. We need everyone to play their part, understand that it takes time to develop expertise and mastery over a subject matter, and that's okay. One need not necessarily wait until they get their A-bomb certification to begin treating people with obesity, right? So
Right.
it's where we need people right now. And then one thing happens after another. You have some successes with patients that increases your interest. You get to mix and mingle and talk to and network with colleagues and learn what other people are doing. And that's encouraging. And so for most of us, it takes time. It takes years to develop the mastery over a subject matter like this. But just get started. Don't wait. Your patients need you, and they need you now. So start with fundamental CME education, what have you, and begin to engage in the process. That's what I would tell colleagues at this point.
I love that. Well, Jeremy, this has been an awesome conversation. I love talking with you about this. I really appreciate and respect your ability to share your story as a person and as a person, who's in treatment for a lifelong chronic disease. And it's really inspiring. Thank you so much.
Thank you very much.
We'll see you soon.
Thank you.